Well, first of all, welcome. My name is Ken Thorpe. I'm the chairman of the Partnership to Fight Chronic Disease. I want to welcome all of you to our event here on obesity and some of the economics around it. This is a fun place for me to be. I spent many years living here in California, so it's always great to come back. It's a wonderful state. Any opportunity I have to come back, I certainly take it.
When your mother is diagnosed with type 2 diabetes, the question is not, what does it mean for mom? The question is, what does it mean for the family? When you're obese, the chances of developing other chronic conditions goes significantly up. But maybe an even more scary statistic that just shy of 20% of children in our nation are obese. And those two statistics, by the way, are growing. Because so many Americans are a little overweight, we pay more in gas to help get ourselves around. $3.4 billion more in gas costs, let alone the emissions that come with that. Actuaries estimate that the U.S. Economy loses in decreased productivity because of the health of our workforce, obesity and obesity-related conditions. But when we look at healthcare costs in general, we can also divide it into obesity and obesity-related costs that are spiraling up. And so, wait a minute, you mean this whole federal government shutdown was because of obesity and diabetes and heart disease and hypertension and things like that? In many ways, yes. So we can scream all we want, Democrats and Republicans, and how we need to work together for the future of our nation. But we can also look to ourselves and to our friends and neighbors and say, hey, let's get a little bit healthier. Let's get fit. And our nation will be better off for it. How is that for part of the solution?
The Medicare program, which I'll focus somewhat on, really doesn't do a good job in the traditional Medicare program to do care coordination at all. And it really significantly lacks in, I think, intensive lifestyle interventions that would make a difference on the growth in obesity as well. And I challenge you to think about this in terms of both the state and federal framework. If you think about a lot of the discussion that goes on in Washington about how to reform Medicare or Medicaid, or how states are approaching this, how much of that discussion is really focusing on doing something about that top line? Really trying to slow the progression of obesity as a major underlying driver of rising healthcare spending? And I think the answer is very little. Most of the discussion is focusing on perhaps issues around how competitive the market should be, but a lot of the tools that the Congress uses to control the growth in entitlement spending really has nothing to do with the underlying drivers of why spending is going up in the first place. Because all they're largely doing is cutting payment rates to healthcare providers. That saves that money in the federal budget. But we've got to get them to focus on this as much more than a budget-driven exercise and much more of a healthcare and population health-driven exercise. So not only do we have more people who are obese, the growth in spending per person for an obese adult is much higher than for a normal weight adult. So we have this really compounding leveraging on the growth in healthcare spending of having more adults and kids considered obese. And for each one of them, the per capita growth in healthcare spending grows much faster over time than it does for a normal weight patient. So virtually all the spending in the Medicare program is associated with patients with multiple chronic healthcare conditions. So about half the population of Medicare is being treated for 5 or more chronic conditions. That accounts for about 80% of spending in a given year. So if you want to put a clinical face on it, which I think is important to think about in the context of how we do healthcare reform, the type of patients that's driving the growth in spending and accounting for most of the growth in spending is an overweight, hypertensive diabetic with bad cholesterol, pulmonary disease, back problems, asthma, and is depressed. That's our patient. Now that's any one of us on any given day. But that's the patient. And if you think about it, most of those things are potentially preventable. And if we manage that patient and engage them in doing appropriate care coordination, they can have a better quality life, and we can do it less expensively. So you would think in the context of a broad debate about healthcare reform, that the structure and the focus of reform would really be on developing a healthcare system that does a better job of averting disease in the first place, a better job of detecting disease so we can engage earlier, and a better job of working with and managing patients with multiple chronic healthcare conditions.
One of our core values as an exchange is that we be a catalyst, that we use our role in the marketplace to stimulate new and innovative approaches for improving quality, for promoting prevention and wellness, and for reducing healthcare disparities. And so when we talk about standing up the exchange, there are really three principal foundations that we have got to get right: affordable health plans, effective outreach and marketing, and smooth enrollment. So first is affordability, and I think everyone's well aware the federal law includes a significant investment in federal financial assistance for low and lower income populations, which reflects policymakers' interest in ensuring that premiums and out-of-pocket costs do not become a barrier for low or lower income populations to access the services they need, and also an interest by policymakers to facilitate access to evidence-based and appropriate preventative services. Between the availability of the tax credits, the availability of subsidies for out-of-pocket expenses, the expansion of Medicaid, the significant majority of lower-income Californians who are uninsured in our state will be eligible for some level of federal financial assistance. But as Ken noted, and we all know, a tax credit, a subsidy, does not by definition make healthcare affordable in a sustainable way. That is really going to require us collectively getting at some of the underlying issues associated with the financing and delivery of healthcare. And so in that respect, Covered California has some very interesting and important tools that distinguish it from at least some of the other state-based exchanges, and certainly from the federal exchange. And in that respect, the most important is that we had the authority to be an active purchaser, to be a selective contractor in the marketplace, to effectively say, yes, there are federal minimum standards that qualified health plans have to meet per the federal law. But in California, we established our own standards above and beyond those federal requirements, with a particular focus on quality, on delivery system reform, and network management. Those standards, which I'll touch upon in a moment, really reflect California's emphasis and priority in terms of promoting access to affordable quality care, and our recognition, as I noted, that if we're really going to get at the underlying drivers of cost and advance that piece of the triple aim related to lower per capita costs, we really have to reform how we deliver care, especially for those with chronic diseases. So using our selective contracting authority, we selected 12 health plans that you see here to serve as our partners. They include the largest plans in the individual market, as well as a number of our regional plans and a number of our local Medi-Cal plans, including LA Care here in Los Angeles. Now, the terms of our relationship with these 12 plans basically reflect a commitment by these plans that they're going to work collaboratively with Covered California to promote care coordination improvements, to foster prevention and wellness, and to seek ways to reduce costs by improving care. It's not going to happen overnight. Not only does it require partners, it's going to take some time, but we feel that through the building blocks we've established through our model contract, we are establishing a very solid and responsible foundation here in California. So as we open our doors, as I said, we are being pragmatic. Our focus is very, very keenly on the importance of smooth implementation and maximizing the number of lives that enroll in Covered California. We know that our aspirations in terms of better quality and better value and better health for California consumers is dependent upon our early success around enrollment, both in terms of number and risk mix. I'll close where I ended with, or I'll close where I started with what Senator Pittio talked about in terms of, there's something that each and every one of us can do. Reversing the trends, tackling the numbers and costs that Ken began the morning speaking to so directly. It isn't going to happen by virtue of any one sector, any one system, any one action. It is going to require all of us to come together and be a part of the solution and to be in it for the long haul, because reversing these trends, both in terms of obesity as well as the economic burden, isn't going to happen overnight. One of our core values is partnership. So I really want to underscore that for your partnership, as you look to the work that you continue to undertake together across multiple systems and sectors to reverse these trends, to get at the economic burden of overweight and obesity, I really encourage you to look at the healthcare system and to look at purchasers, particularly these new health benefit exchanges. I believe we have a very important and powerful role to play, not alone, but in concert with many other efforts. We bring a sense of urgency, we bring a commitment, and working together, I'm confident we can make an important and meaningful and measurable improvement in the health of Californians and the health of Americans broadly. So keep up the good work and know that you have a partner in Covered California. Thank you.
Let me just thank all of you. It's quite a thrill for me, for a person that's been in the fight of public health for more years than I care to remember, to see these many people, all of you, leaders in what you do, standing up and willing to participate to fight chronic illnesses, and especially obesity. Thank you. The insurance companies have simply got to begin covering obesity treatments. Sometimes people can't do it themselves. That includes Medicare. It also includes the exchanges and private plans. The exchanges are also extremely important. You know, it's nice to find an Affordable Care Act, and I'm not taking a position on it. Some of you are for it, some are opposed to it. But the nice thing about the Affordable Care Act is there's some provisions in there doing with preventative health that we've never had before. And I feel partly responsible for that because I fought for that kind of language when I was secretary. And I went to the departments of health and the committees on health and the people with jurisdiction, and I told them that if we're going to ever curb the cost of health care, we've got to be involved in the fight on preventative health. Obesity, you know, is more than appearance or lifestyle. It has very real consequences in our health, our appearance. The growing obesity problem is causing so many other chronic diseases to worsen and affect the quality of health. If you have good health, ladies and gentlemen, I don't care if you're rich, poor, whatever. If you got good health, your quality of life improves considerably, period. No consequences, no changes. And those chronic diseases are killing more and more of our family members and putting a massive strain on the healthcare system that we want to make sure perseveres and improves. In fact, just recently, this summer as a matter of fact, the American Journal of Public Health shows that 3 times more deaths than previously thought are believed to be related to obesity, both among men and women, and yes, at older ages. That, to me, quite simply, is unacceptable. That you can enjoy the foods that you want. It's not my job, and it's not the government's job to tell you what to eat and what not to eat. But I'm here to tell you to eat and drink in moderation. Balance those meals with healthy choices. Don't go back for seconds. And especially don't go back for thirds. And I know it's easier said than done, but in one of my companies, we had a cafeteria. And on the board, I made a directive. I said, let's subsidize and give away fruits, vegetables, and salads. Maximum pay is $1. You go in and get your salad, your fruits, your nuts and vegetables, pay $1. Get a hamburger, it costs $10. Cheeseburger, $15. French fries, 10 cents a fry. You know something? Guess what happened? They went to the fruits and vegetables and salads. It works. Money has a way of motivating people to do what is right. And you know, you walk into a hospital, what's the first thing you smell when you walk into the hospital these days?
French fries.
No, you smell pizza. The biggest seller in hospital cafeterias is pizza. And if you really want to, have a change, why serve pizzas in hospitals? I don't know. I know after this, I know my handlers are going to be back to the pizza industry is going to be after me again. But it doesn't work for everyone. For a wide variety of reasons, we can lecture, you and I can cajole, and we can plead all that we like. But we still have an obesity problem. More than 1 in 3 American adults are obese. And the experts tell us it's only going to get worse. And that's where the policy solution comes in. As you know, the American Medical Association recently, and I say rightly so, classified obesity as a disease. And that, of course, has sparked an important conversation and a big controversy about treatments and the coverage of obesity. Let me reiterate. I believe that Medicare must begin covering obesity treatments because chronic diseases are a primary driver of higher costs in the Medicare system. And I ran that system, I know it does. If Medicare begins covering obesity treatments, it's going to significantly reduce the long-term costs associated with obesity-related chronic diseases. And I urge the Congressional Budget Office to take a look at not just the price per prescription, but also at the downstream savings for the overall Medicare system. But just think what all of us together can do. Like we've been able to do it on tobacco smoking. It's gone from 50% down to just below 20%. What we've done in AIDS, we do the same thing on obesity. And as I said, chunky's good, but slim is better. Thank you very, very much.
It's a joy to be with you and have such a distinguished group of panelists to introduce. Let me just talk about this issue a little bit. The panel is going to talk about diabetes, obesity, diversity, and disparities. And it's very clear that we have opportunities, we have numerous challenges, and a lot of what we tend to discuss is where most of the money is. And the money's in the sickness care system. But if you look at the determinants of health, the major determinants of health and the disparities are found in our social, our economic, and our physical environments.
You know, the top 4 leading causes of death for Latinos in California are heart disease, cancer, stroke, and diabetes. And that accounts for 54% of all deaths of Latinos in California. And if you take a step back, I have a little bit of engineering background, and when you take a step back, let's do a little root cause analysis here. In public health, we all call it moving upstream. So let's move upstream a step. What's going on here? If we look at heart disease, cancer, stroke, and diabetes, you move upstream. Obesity is a major part of a contributor to all that. But let's take another step back and root cause again. So we got to obesity. Well, what's causing obesity in our communities? And I should start with, before I start saying what I believe these factors are, to talk about how happy I am that the Affordable Care Act and the health care advancements have, how far they've come, and they can treat people that have disease related to obesity. That's super important. But just treating something in the pipe is never going to prevent it or solve the solution or prevent it from happening in the first place. So when I think of diabetes, I actually think about the environments that promote diabetes, the environments that cause diabetes, and I start to think about, well, what is it that we can do in those environments to stop diabetes from happening in the first place? And so I was very happy to hear your introduction where you're talking about the social determinants of health, because for me, diabetes is a health equity issue, it's a health justice issue, and when we start looking at the environments, and on the reference of TCE, health happens here, and when we look at those life expectancy differences, as you mentioned, it's not a difference in biology, it's not a difference in genetics. What it is all those little things that add up every day that are present robustly or absent in a community that people are exposed to on a day-to-day basis that add up and just chip away at our ability to be healthy, and I would even argue that promote chronic disease such as obesity.
Did you know a park can prevent heart disease? A grocery store can stop diabetes. That a drinking fountain can put an end to childhood obesity? Did you know how long you live depends on where you live? Children born in neighborhoods with safe parks, fresh produce, and clean drinking water can live up to 20 years longer than those born in places without them. We can do better. We have the power to give every child a longer, healthier life. To build a stronger California. We can change the places where we live, work, and play. Because health doesn't only happen in a doctor's office. Health happens here.
The little clip that we just showed you, I think, lifts up what our core framework and belief really is. And that's that the doctor's office is not going to be the place where we find the opportunity to prevent diabetes, to prevent obesity. That we really need to look to our neighborhoods and our communities and what is going on in those neighborhoods and communities, and Javier already referred to this, that is making the healthy choice such a difficult choice. We need to look at our schools, our neighborhoods, our healthcare system, of course, the private sector. And many of us have spoken already about everybody has a role to play. Let's just pick schools, for example. We have worked very hard in California as a leader in the nation to address the issues of unhealthy food in schools. For many, many years, schools were offering full sugar sodas in their vending machines. They still offer full sugar energy drinks in their vending machines. And kids from the ages of 8 years and up who had a little change in their pocket could go into the school and purchase a full sugar beverage and have that instead of their lunch. And many of them did. And the recent developments through state legislation, and actually LA County, to their credit, was the first school district that actually banned full sugar beverages in the school system. But that was then made state legislation and is now federal legislation that covers the whole country. And I think some of these changes have been the source of the plateauing that we've seen in the childhood obesity.
We say health happens, but obesity and diabetes does happen. And so we're pleased to have a practitioner with us on this panel. Please, Dr. Mucciose.
As far as I see it, California is going to get hit extremely hard over the next 5 years by obesity. The reason being is because of our unusual racial mix. We're roughly 62% a mix of Asian and Hispanic. The rest is Caucasian and African American. The reason why I say that is if you put 30 pounds on an African American or Caucasian, they don't quickly move to diabetes. They actually do okay. You have to put 50 or 60 pounds. But if you put that same amount of weight on an Asian or Hispanic, they're moving towards diabetes extremely rapidly. So we've got to remember the majority of our population is in this group, unfortunately. So we're going to get hit really hard with this. And I already see it in my clinic. I mean, I can't tell you the number of young Hispanic and Asian women that are 36, 37, already moving into type 2 diabetes. The scary part is that they have gestational diabetes and they're like 20s already. So again, we're going to get hit really hard. And I can't underemphasize this enough. There's some good news. If somebody will go back to our 200-pound person, if they lose 5 to 10% of their weight, this was mentioned earlier in this particular study they talked about, In this study, they lost 7% of their weight. That was enough to prevent over half the diabetics that were going to become diabetics in that study in just a 4-year period. Unfortunately, there's a lot of misinformation in the field of obesity. So all the time you're getting bombarded with really crazy ideas for weight loss that really don't work. But not just patients, physicians. Physicians are not trained in obesity. So, in my very short conclusion, if I can try and give my gift that I would love to see someday is one that we need to educate physicians and all health caregivers on obesity. And one easy way to do it is mandatorily make it for doctors when they re-up for their license in California. We do this with pain. If you don't know about pain, you actually have to take 10 units of CME to get your license for the next couple of years. Why not do this with obesity? Make doctors learn about it. Same with RNs, nurses, same with psychologists, same with all, because again, it's by far the most prevalent problem that they're all seeing. And you think, diabetes is a problem, depression is a huge problem in this population, because again, these folks are fighting biology, and yet they get ostracized for their weight.
If you look at how we spend money on agriculture, right? What do we fund? We actually fund soy, corn, rice, wheat, and then what happens? So you have this massive tax-subsidized proliferation of these products, of these commodities. What do you do now? Well, you have to use it. So how have we begun to use it? Well, we've begun to process it and put it back into food that's very cheap calories. And we are now paying for it. So on one end, our tax dollars have sponsored and subsidized this problem. On the other end of it, now our healthcare system, programs like Medi-Cal, Medicare, now are going to be drained because now we have to treat the ramifications of this. And we talk about the economics, how expensive, fresh fruits, vegetables, whole grain foods are, whole foods are, but cooking is still cheaper. The problem is many of the families, like my family, my mother was a single mother with 3 boys, she had to raise by herself. My mother didn't have time between her 2 jobs and her schooling to come home and cook every night. And so a lot of times fast food replaced that. So again, even when we talk about the cost of things, the real cost of fast food isn't paid at the counter. The real cost of fast food is paid years later at the doctor's office, or in the emergency room, or after the surgery has taken place. So there's another economic component, and it, again, why I'm a fan of healthcare reform. At the end of the day, everyone has to pay. So people say to me, why should I pay for this person's insurance? You already do. We have Cobra and EMTALA laws that if that person is hit by a car and brought to an emergency room, guess what? It's going to be paid for. Somebody's going to wind up having to pay for it, even if they never can. And it's the same thing with these chronic diseases. I want to also talk about something that's a little bit more sensitive, and something that's not polite to talk about in a room full of very educated and polished people, and that's institutionalized race work on this. When you're in an environment that's stressful, where there's higher violence, poorer nutritional outcomes, parts that you don't feel safe to play in, more family dysfunction, poor school districts, it raises your allostatic odor, or your stress levels. And one of the hormones that's released in that is cortisol. We now know that stress response, because how difficult it is to lose weight, actually changes the way you express hormones and how sensitive your insulin will even be. It actually impacts the way that your body responds. Then, of course, that plays into things like epigenetics. Now, generationally, these things are going to be passed down. The reality is that we have people who live in very high-stress areas, and there are studies that would suggest that if you live in these neighborhoods, crispy, crunchy, salty, sugary, fatty foods actually taste better than healthier foods, making it even more difficult to make the right choice besides the cost issues and the access and availability issues. So we have to begin to actually step back and look at mental health as a component of this. We have to actually draw back and say, here's another component around depression, which was mentioned, and how that impacts neighborhoods and communities. But then we have to really begin to look at what do we do to overall reduce the stress it takes to live in some neighborhoods. If you've ever, like I have, lived in neighborhoods where police helicopters are always flying overhead, and you hear gunshots in the distance, it is a very frightening thing that even can cause you nightmares at night. And I want to submit to you that part of the disparities around obesity and diabetes actually plays all the way back into things that often we think are completely disconnected.
Anyone who takes a closer look at the state of the nation's healthcare understands how important the work that everybody here in this room is doing and what PFCD, the Partnership to Fight Chronic Diseases, can do. Right now in America, cancer and diabetes, heart disease, stroke, obesity, and other chronic diseases are killing more than 1.7 million people every year. That's more than 70% of all deaths overall due to disease. And chronic diseases, as you have heard, are responsible for more than 85% of all of the costs that are borne in Medicaid and Medicare. So more than any other organization, PFCD is bringing together policymakers, insurers, and the public, and bringing them face to face with these overwhelming facts. It's leading the way in mobilizing Americans to demand that the nation provide effective health care for our citizens by detecting, by preventing, and by managing chronic disease, and by encouraging healthier living. So state and local and national leaders must change the way that they think about obesity, to bring our healthcare reimbursement system into the 21st century and make sure that it recognizes long-term value. We need to help our policymakers understand that comprehensive behavior programs that are led by wellness professionals work better than a single visit to a doctor's office. We need to learn that community-based weight loss programs for people 60 and older could save Medicare between $7 and $15 billion and could prevent the system from financial collapse. The burden of obesity is simply too great for our political leaders to ignore. The opportunities to make a difference in people's lives are too great for us to let them slip through our fingers. Our companies will continue to work with you all and with a partnership to reverse the dangerous trends in obesity. And together, we hope that all patients that are confronting obesity and confronting chronic disease can have a healthier and brighter life.
So I hope we leave with a sense of urgency, and also hope that we leave with a sense of optimism, because there are solutions, and there are ways that we can go ahead and approach this. We just need to change some of the thought process about how we traditionally looked at healthcare reform, and really recognize it's not just about health insurance, but it's about population health, public health, prevention, detection, and really changing the way that we deliver and provide healthcare services to patients. So I thank you all for coming, and I hope you have a great remaining part of the day and enjoy the rest of your lunch. Thank you.